Dr. Aditi, you can start the meeting.
You can start, Dr. Aditi.
Yes, ma'am. So a very good evening to one and all. I would like to welcome you to the second online monthly meet of SFM Telangana. So before we start today's proceedings, just quick recap regarding the previous session. This was held on 16th of March, where we had discussed about the fetal heart and the genetics related to it. The session was well appreciated and we are hoping the same for this time. So I would like to first invite Dr. Chinmay, President SFM Telangana, to start with the welcome address.
Thank you, Aditi. A very good evening to all of you present here. I would acknowledge the presence of our founder, President Dr. Ashok Khurana, our mentor forever, and somebody who inspires us with all his vision. TLN Praveen, our past president of the SFM, Dr. Bimal Sahani, the president of SFM, and Geeta ma'am, our senior advisor for the SFM Telangana. At the outset, sir, thank you very much for having a separate chapter for Telangana. And the very purpose of having this chapter was to give an outlet to a lot of people who've been working in areas that have not received as much exposure as those that are in the frontline cities. So we are very happy today that we have a participant from Warangal, Dr. Madhavi Lata, who's been working there for many years and has been contributing to the healthcare system in the city of Warangal. And today she will be presenting one of her cases in this forum for discussion. We welcome Dr. Adi Narayan Makam, who's from Bangalore and a real maverick in the science of fetal medicine. And when it comes to heterotaxy, very few people understand heterotaxy as well as it does, because, you know, he understands everything that's out of place. So we are very happy to have him here. And I can see Dr. Sunil Jaiman also online, and he is a fetal pathologist par excellence. And he's all around the globe. So I don't know where he's trotting right now, but very warm welcome to you, Sunil, sir. And with this, I think we'll get on started. We have Dr. Aditi as the master of ceremony taking us through the presentations. And we have a few case presentations followed by an expert panel discussion with all the luminary stalwarts that we have here. So over to you, Aditi. Dr. Aditi, will you please introduce the first speaker? I think we are having some connectivity issues. So let me just invite on stage Dr. Adi Narayan Makam and Dr. Geeta Kolar, who will be the chairpersons for the first session. Dr. Adi Narayan Makam is the director of Adi's Fetal Care in Bangalore, and he's a very well-known name in fetal medicine in India. He doesn't believe in 1D or 2D. He directly goes to 3D for everything. And the way he does 3D is par excellence. His pictures are beautiful. And he says, understanding the unborn, you know, UTU, that is his sort of catch line. Am I right, Dr. Adi?
Yes.
Welcome to our meeting.
Thank you.
And
Thank you very much.
Geeta ma'am is again somebody all of us know. So this is the illustrious CV of Dr. Adi Narayan Makam. He's had training in the United Kingdom for over 10 years and had been a lead consultant in fetal medicine at the Royal Gwent Hospital from 2010 to 12. And thereafter, we are lucky that he came back to India and taught us how to understand the unborn. He's a very passionate teacher, a wonderful human being with many facets to his personality. So we will learn how much he understands heterotaxy in the course of the evening. Dr. Geeta Kolar is the other expert, and I am in no position to introduce her to this gathering because she is the one who introduced me to ultrasound way back in 2004 when I used to watch her doing scans in Fernandez Hospital. Madam is really a great academician and a very good teacher. So we have two very luminary experts for this session. And Aditi, you please call on the first speaker and we'll start there. Unmute yourself, please.
Our first speaker for tonight is Dr. Madhvi Lata. So Dr. Madhvi has had 22 years of experience in fetal imaging and in the radiology department in Warangal Medical College. She is also the managing director of Vinuta Scan Center and has had several publications in reputed journals of rare cases. She has also recently presented fetal venous abnormalities in the Fetal Cardiocon in 2019 Delhi and in the 30th World Congress at ISWA 2020. So with this, I would like to invite Dr. Madhvi. Ma'am, can you please continue?
Dr. Madhvi Lata will be presenting a case on situs inversus. You can share your screen, Dr. Madhvi. You can make it full screen and then it's all yours.
So good evening all. Thanks Dr. Aditi, and thanks for giving me this opportunity to the SFM Telangana chapter. So today first I am going to start with the sequential segmental analysis of a complex cardiac abnormality. So the basic approach for sequential segmental analysis are initially you have to assess the fetal right and left orientation and the visceral, abdominal and situs. Then look for the veno-atrial relationship and atrial morphology, atrioventricular relationship and ventricular morphology, and look for the ventriculo-arterial relationship and great arterial relationship. All these are the basic steps for the fetal echo. And for the orientation of the fetal situs, it depends on the fetal eye and the position of the fetus to the maternal eye. So for first, you need to take an axial sweep from the abdomen to the thorax. Look for the stomach and the apex of the cardia, whether they both are on the same side. That means these structures, they are in the left side. It is not that they are in the left side, but they are in the same, you know that they are on the same side. If it is not there, then that is the viscerocardiac heterotaxy. Then look for the orientation of right and left sidedness of the fetus. For that, you need to take the axial section of the abdomen, look for the descending aorta and draw a circle communicating the descending, connecting the descending aorta, stomach, umbilical vein and the liver. If the circle is going in clockwise direction, then the fetus has to be in the cephalic presentation. If it is going on anti-clockwise, then the fetus has to be in the podalic presentation. If it is not following this, then that is the the abdominal situs is situs inversus. Here, this is the case of 21 to 22 weeks fetus showing cardia and cardiac apex and the stomach in the opposite direction. So it is a viscerocardiac heterotaxy. If you go in detail, so in this section, if you draw a connection from the descending aorta, stomach, umbilical vein and liver, the circle is going in anti-clockwise direction, whereas the fetus is in cephalic presentation. So the situs is here, situs inversus position. Whereas regarding the heart, if you see the anterior chamber, the apex is towards the left side. But in detail, if you go by morphology of the chambers, the right-sided, that is anteriorly placed ventricle is showing forming the apex, and the AV valve is basally placed. So this is morphological left ventricle, which is placed on right side. Here on the left-sided ventricle showing moderator band and the AV valves at the apical position. So this is morphological right ventricle. So regarding the veno-atrial connections, this is important for situs, where you can see the pulmonary veins are draining into anteriorly placed right-sided atrium. And if you see the atrial appendage is finger-like here, but normally right-sided atrial appendage should be broad-based, whereas here it is finger-like. So this is morphological left atrium presented on right side. If you see the left-sided atrial appendage showing broad base. So this is morphological right atrium presented on the left side. So here, if you see in this clip, you can see trace the IVC from the abdomen into the thorax, into the heart. The IVC is draining the left-sided atrium. Also, you can see the IVC and SVC draining into the left-sided atrium. So this is the 5-chamber view. You can see the small calibered aorta, small calibered aorta. And here in this, you can see the large calibered the pulmonary artery arising from the morphological right ventricle that is presented on left side. So the ductal arch is prominent and it is on right side. Even the descending aorta is on right side. So right aortic arch. So this is the 3-vessel view showing the main pulmonary artery, aorta and SVC. The caliber of aorta, ascending aorta is almost equal to the SVC. So it is very much narrowed. Here in this clip, you can see the aortic arch is missing and the aorta ascending small calibered ascending aorta is going straight into the neck. So there is a high possibility of interrupted aortic arch. This is the 4D stick acquisition showing there is a VSD with aorta is more committed to the left-sided ventricle. That means the morphological right ventricle, and the pulmonary artery is arising from the morphological right ventricle. So it is DORV. And these are the autopsy findings which come from artery, aorta, and SVC. And here the stomach is on right side and apex of the cardia is on left side. And you can see the aortic arch here. It is giving rise to the branches. And in this also you can see this is the ductal arch and this is the aortic arch. After giving the 3 branches, aortic arch is connected to ductal arch. So there is an aortic arch, but it is very much narrowed, suggestive of severe coarctation of aorta. So in this case, now we have seen that aorta and stomach on left side, IVC and liver, aorta and stomach on right side, IVC and liver on left side. Here GB is not visualized. And regarding the heart, right cardiac chambers on left side and left cardiac chambers on right side. So the cardiac apex is on left side. There is DORV with severe coarctation. So finally, this is the case of situs inversus totalis with levo rotation of the cardia showing DORV with severe coarctation of aorta. These are some more cases regarding the situs inversus totalis. So this is the case of 21 weeks fetus showing situs inversus totalis with stomach, aorta and GB on right side, IVC and liver on left side, with right cardiac structures on left side and left cardiac structures on right side, suggestive of situs inversus totalis. Regarding the cardiac intracardiac abnormalities, there is unbalanced AVSD, both great vessels arising from morphological right ventricle with small pulmonary artery and absent ductus here. You can see the ductus is absent. So, and there is thymus not visualized. You can see aorta is there is no gap between the aorta and the anterior thoracic wall. So thymus is not visualized. These are some more cases. It is around 23 weeks fetus showing situs inversus totalis. The intracardiac morphology is normal, but there is a cleft lip and palate. And this is one more case of 21 weeks fetus showing situs inversus totalis with double SVC. So regarding the situs inversus totalis, it is a mirror image of situs solitus. The incidence varies from 1 in 2500 to 1 in 20,000. Here the association with congenital heart diseases are very much high. It is around 0.3 to 5%. 20% of the situs inversus totalis are associated with Cartagener's syndrome, which is an autosomal recessive condition. It is a subtype of ciliopathy. Here they will have the repeated recurrent respiratory infections and subfertility. So the situs inversus totalis, the commonly associated congenital heart disease with that is TOF and VSD and DORV, etc. It is also associated with maternal diabetes mellitus and consanguinity. Not only that, we should know the previous history of situs inversus totalis and also screen the parents for situs abnormality. So my conclusion, these are the main steps unraveling the multiple components of the major cardiac anomaly, mainly involving the situs. Situs inversus totalis without structural or congenital heart disease can be missed in so many times. So always look for situs carefully and follow the basic steps. Thank you. Thank you for all.
Thank you, Dr. Madhavi, for the different number of cases and the extensive, detailed evaluation that was done. We have a few minutes for discussion right now. If there are any questions or anything.
Dr. Adi, can you take on the discussion?
Yeah, Dr. Madhavi, wonderful presentation, nice images, nice 3D. More than that, the autopsy images are wonderful, very impressive. My first question is, your first case, is it a heterotaxy or a situs inversus totalis?
Sir, situs inversus totalis with levo-rotation of the heart. Sir.
No, I mean, as much as I understood, situs inversus totalis means is a complete mirror image. So heart should be on the right side, not on the left side.
Yes, sir, it is, but there is a levo-rotation along with the situs inversus, sir. Because the situs
if you look at situs alone, this is ambiguous situs. So abdominal situs is on the right side, the thoracic situs is the left side. What about the lungs? Did you have wide lungs on both sides, or?
No, sir. Both are morphological. Right-sided lung is on left side and left is on right side, sir. So it is situs inversus totalis, sir. Only the cardiac axis is rotated. That's all, sir.
I know it's a complex one, but to call it as a situs inversus totalis, all of them should be reversed.
The right atrium is on left side and left atrium is on right side. Basically, situs is more favorable with atrial connections. Is it?
I mean, there is a lot of confusion in the literature regarding what do we name, how do we name them. Yes, from the definition perspective, situs inversus totalis is complete reversal of the normal situs solitus. And if there is any change, it is heterotaxy.
Yes, sir. Yes, sir.
So if you in our autopsy specimen, if the lungs are also reversed, it's a complex situs. Yeah, it's a complex situs problem. It will be difficult to name exactly what it is. So I would rather go in favor of heterotaxy rather than situs totalis inversus. Other people, other experts think. I would go as heterotaxy.
Okay. I think basically it is a situs ambiguous.
Yes, sir.
I mean, because if it is a situs solitus, the apex of the stomach are on the same side. Whereas if it's inversus, it is on the opposite side. That is almost the mirror image, that is flipping.
Yeah.
Whereas whenever you have opposite, that is the stomach on one side and the heart apex on the other side, you call it as a situs ambiguous. I think basically this is what we need to understand before we go further into the cardiac abnormalities, because unless we understand this, then the progress will be easy. Yeah, so I think we can go ahead.
Thank you for the experts, because I think that the message was quite clear that we should not label it as one entity unless everything falls into the definition of that entity. So instead of calling this as a situs inversus totalis, it would be good to just call it as part of a heterotaxy with some ambiguity in the situs. Thank you so much. We'll move on to the next case, Aditi.
So our next speaker for tonight is Dr. Sudha. Dr. Sudha is a consultant at Resolution Fetal Medicine Center. So handing over to you, Dr. Sudha.
Good evening, everyone. I am Dr. Vidya Sudha from the team Resolution Fetal Medicine Center and Research Institute, Hyderabad. I'll be sharing my slides. So I'm here to present rare case findings, which is from our unit. Sorry, ma'am.
Share your screen. There's the green share button down there.
Yes, ma'am. Could you see my slides, ma'am?
They're just coming on.
Your screen sharing is paused. That's the message I'm getting, ma'am.
No, have you opened your presentation? You open your presentation and then share the screen.
Please share again.
Make it full screen. Start.
Thank you. I'm here to present a rare case from our unit, and Mrs. X, she's 21-year-old, primary gravida, not married within the consanguinity, and referred to us at 23 weeks. She spontaneously conceived, an NT scan was done at other center, which is reported normal, and she did not do any biochemical screening for fetal chromosomal aneuploidies. So before starting a stepwise analysis of the fetal scan findings, I want to tell you about the fetal orientation. One second, ma'am. I want all of you to know about the fetal orientation on the day of the scan. The fetus in cephalic presentation with supine position and spine facing down. According to the right hand thumb rule, where the palm of the hand will be representing the fetal face, and the thumb will always represent in the fetal left side. So when the fetus in cephalic presentation and supine position, spine facing down, this will be the image. So this will, the cursor is showing the left side. So the apex of the heart in the axial section of the thorax in the apical four-chamber view, the heart is facing towards the left side, but the stomach is there on the opposite side. This is a dextrogastria. So we could also see a heart with a left axis deviation. So this is a quick overview of the same thing which I have explained in the previous slide. So when you follow my cursor, so this is the right hand thumb rule. So when the fetus in cephalic position and supine and back down, the thumb will always represent the fetal left side. So you can see the stomach in the left side and the apex of the heart in the left side. This is a normal thing. Next, the normal cardiac axis, usually it will be 45 degrees plus or minus 20 degrees to the left side. But in this case, we can see an exaggerated left axis deviation. And adding to the cardiac findings, we could also see an AVSD. You can see here, sorry, VSD. And also in this video, we could see a persistent fetal bradycardia, which might be due to the heart rhythm abnormalities. So which is an important finding in left isomerism of heterotaxis syndrome. So these are the cardiac findings and also the stomach, the dextrogastria. Next, we could also see an interrupted IVC with IVC with an azygous vein. And in this axial section of the fetal upper abdomen, we can see here two vessels. This is a double vessel sign. I will describe it. So a double vessel sign is that azygous vein located along the fetal spine posterior to the descending aorta. So this is known as a double vessel sign, and we can see it here. So this is seen in interrupted IVC with azygous vein, which is also seen in left isomerism. So this is a schematic diagrammatic representation of the azygous vein, where we can see the interruption of the IVC and the azygous vein here. Next, in the fetal abdomen, we couldn't see a gallbladder, and this might be due to the evolving biliary atresia that might be like diagnosed postnatally, definitively. And also we could see prominent bowel loops that might be due to the bowel malrotation. So I'll give you a quick overview of all the basic definitions. Situs is defined as arrangement of the viscera, atria, and vessels within the body. The situs soltus is that normal arrangement that left side organs are present on the left side and the right side organs are present on the right side. In case of situs inversus, that is inverted arrangement, mirror image arrangement, that is the left side organs are present on the right and right side on the left. So situs ambiguous is that one which is not either situs soltus or either fit into situs inversus. So, but there are some disturbances in the arrangements along the left and right axis. So as I said, neither be a situs soltus or situs inversus. So they are divided into two types, left isomerism or polysplania and right isomerism or asplenia. So to label it as left isomerism, we should see at least 2 ultrasound findings out of these 3. So this is like situs ambiguous, discordant laterality of the stomach, the dextrogastria, or portal sinus or of the gallbladder, and azygous continuation of the interrupted inferior vena cava and heart block. So either 2 of these 3 must be present. In case of right isomerism, either 2 of these 3 findings must be present: cardiac defects, situs ambiguous, the abdominal situs, and a juxtaposition of inferior vena cava and aorta on the same side of the spine. In right isomerism, we could see it on the right side. The 2 vessels will be seen on the same side, the IVC and the aorta. So this is according to this paper. So concluding about our case, so we could see all these findings: the azygous vein, double vessel sign, left axis deviation, VSD, cardiac rhythm abnormalities, I wanted to point it out, and dextrogastria, suspected biliary atresia, and intestinal malrotation. So putting it together, so we diagnosed it as mostly a heterotaxy syndrome with left-sided isomerism. Explain the findings and also the outcome, like the prognosis to the couple and the rare possibility of genetic and chromosomal association. But they opted to terminate the pregnancy, and we have given the option of the autopsy, but the couple denied that option. So a quick thing, so after diagnosing a heterotaxy syndrome, we need to label it in this manner. So stepwise and logical progression of analysis. So first we have to label the position of the heart in the chest, orientation of the cardiac apex, veno-atrial connections, relationship and arrangement of the remaining thoracoabdominal organs, including the spleen, lungs, and intestines. So we should also put a note on the spleen morphology. So after a quick literature search, so I could find the incidences of these findings. So gut malrotation and biliary atresia are the most common things, which are seen in 40 to 50% of the cases. But in 60% of the prenatal cases, we could see cardiac rhythm abnormalities in left isomerism, which is seen in our case. So usually in left isomerism, early fetal heart block and high drops may be associated, as the cardiac looping and asymmetrical gut morphogenesis are the first events in the embryo which involve the left-right asymmetry. So regarding the counseling, the severity of the cardiac malformation is the main determinant of the outcome. And about the prognosis, we should be counseling to the couple. And the presence of the extra cardiac malformation is associated with the increased morbidity and mortality, which might be associated with the repeated surgeries postnatally. These all things must be counseled to the patients before just they are continuing, and they must be knowing about all these things. Thank you.
Thank you, Dr. Sudha. Your comments, Dr. Adi.
Yeah, beautifully presented, nice images. Sudha, what was the diagnostic features to say it's a left atrial isomerism?
Sir, we could see bradycardia and dextrogastria and also azygous vein. So we probably diagnosed it as a heterotaxy syndrome, left isomerism.
Okay, can you open your first slide?
Okay, sir.
Share your screen again, Sudha.
Okay, sir.
That one, first one.
This one, sir?
Third one.
This
one before.
This one.
Third slide, yeah, that one. So in this one image, can you diagnose this as a left isomerism?
Yes.
So we could see a dextrogastria
Yeah.
and also two vessels. Actually, we could see, sir.
Yeah, here.
And also we could see an VST. So
Yeah. Forget about that. Can you see the stomach and heart on either side of the baby?
Yes, sir.
And can you see the area behind the heart?
Yes, sir.
Double vessel.
Double vessel.
Yes, sir. Yes.
So that is only one is aorta, another is
Azygous.
azygous. Azygous normally present, but will not be easily seen unless it is dilated. So azygous will be present when there is no IVC continuation.
Interruption of IVC.
Yeah. So IVC is a right-sided structure. If the baby doesn't understand what is right, it doubles the left-sided structure. So that's why it's called left heterotaxy. So in that one image, you could make a diagnosis of all left atrial isomerism. What are the criteria? One is your situs ambiguous.
Yes, sir.
Another,
Azygous vein.
interrupted IVC. And the third one,
ABS.
heart block.
Yes.
Heart block again because the conducting system
Will be
majority belongs to right side. Baby has not understood what is right. So that's why it is done more of left.
Okay.
So you don't need to have all the three. You need only two.
Okay.
So in this one image, you can make left atrial isomerism as a diagnosis.
Okay.
Less than 2 seconds.
Okay.
Good. Okay. My another question quickly. Why do you get the juxtaposition of the IVC in right atrial isomerism? Okay. Maybe because the liver is central in position. So that has pushed the IVC towards the left side rather than being on the right side, because the liver occupies the central position of the abdomen. Okay, good. Sorry. Nice presentation. I love it.
Thank you, sir.
Good. Chinmay, you may want to ask.
No, thank you so much. And see, those are the expert inputs which we'll get only from you, isn't it? We didn't think of the liver pushing the, the vessel down there, the vein into the midline. So can you move on to the next speaker, Aditi?
So our next speaker for today is Dr. Aditya Kulkarni. Dr. Aditya Kulkarni is a pathologist. He is an associate consultant working in the Department of Histopathology at the Apollo Health Sciences. And his areas of interest are perinatal pathology, gynec pathology, as well as artificial intelligence and computational pathology. So Dr. Aditya, we are waiting to hear your session.
Hello, good evening, everyone. So I thought today, is my screen visible? And
yes, we can see you. Just make it full screen.
Yeah, and I hope I'm audible.
Yes.
Yeah. Okay, so I thought today, in context of these two previous cases, we could discuss the fetal pathology perspective of situs abnormalities. It's more of a theoretical talk, just highlighting points that we as fetal pathologists look for. And there might be some overlap. Let me just tell you that at the outset, because of with the previous cases, I will try to run through those. Okay. So we'll discuss definitions and terminologies and classification of situs abnormalities, which is admittedly again has already been discussed. We'll talk about situs abnormalities as a whole, and then we'll discuss the approach to situs anomalies on fetal autopsy. Coming to the definitions, situs solitus, as has been told before, is the normal arrangement, and it does not mean just the cardiac or just the thoracic cavity arrangement. It also means the abdominal situs. So you should have levocardia and morphologically right atrium on the right side, morphologically left atrium on the left side. and right lung on the right side, and so on. So also you should have a left-sided spleen, a left-handed stomach, and a liver on the right side. Situs inversus is exact mirror image of that. The heart shows dextrocardia, and one important point to note here is that the heart situs, the heart location in the left hemithorax or right hemithorax does not does not really mean abnormality of the connections, internal morphology and connections of the heart. It just means that the location is different. That we will still need to see on a case-to-case basis. Anything in between is situs ambiguous, basically where we can't classify it either way. We call it situs ambiguous, also known as heterotaxis syndromes, also known as cardiosplenic syndromes. And left isomerism and right isomerism are the subtypes, as has been told before. So just to quickly recap the situs solitus. So you get a morphologically right atrium with a right atrial appendage, which has its own characteristic feature. On the right side, you get a trilobed lung on the right side, and you get the apex of the apex of the heart in the left side at an axis, at an angle of around 45 degrees to the vertebral column, and you get a bilobed lung on the left side. Internal morphology, this is a picture diagrammatic representation of the internal morphology of the atria, which is where you identify the situs abnormalities. So the right atria will show pectinate muscles with a pectinate line here, and the left atria will be much smoother, and it will have a very narrow atrial appendage with pectinate muscle detrabeculations confined to the appendage. And this is what it looks like. This is one of our cases. This is what it looks like on autopsy. So you open the trunk and then you see a dextrocardia, you see a trilobed lung, as you can see here. And the relation of the arteries is normal, the branches are normal. And you can see the atrial morphology quite clearly here. The right atrial appendage will be trapezoidal and more broad, and the left atrial appendage will be narrow and finger-like. By contrast, the situs inversus is as we said, a mirror image. So you will get dextrocardia. I'm so sorry, dextrocardia, and as can be seen here, and the atrial morphology is also reversed. You get a right-sided spleen and you get a right-handed stomach. And this is the diagrammatic representation of the atrial morphology. It is reverse of what was seen before. Bronchial morphology is very, very critical for a diagnosis of a situs abnormality, especially the heterotaxis syndromes. The left bronchus is generally more angulated, and it's a steep branch, and it's hypoarterial. That means that it is going underneath the pulmonary artery. The right bronchus goes alongside the pulmonary arteries and is called eparterial. By contrast, heterotaxis syndromes, as we have discussed before, can be classified into right isomerism and left isomerism, and you get duplication of either side of the structure. So you get both eparterial bronchi, both trilobed lungs, and you get a transverse liver, and you get atrial morphology showing both right-sided atria. And by contrast, you see left isomerism and bilateral left atria. And just to show this is a case, now if you compare this with the diagrammatic representation, this looks like more of a steep angular branching, and both bilobed lungs. So this is a left isomerism. Just a table to highlight the differences between the two. And right atrial isomerism is generally associated with asplenia, whereas left atrial isomerism is generally associated with polysplenia. You get multiple spleens along the greater curvature, and you get duplications of lungs and bronchi, as stated before. As far as overview of situs abnormalities as a whole is concerned, this is again has been discussed. Our importance for us, the importance of situs abnormalities is with the fact that once you see those, you need to look for other abnormalities. You need to, because these are associated more with congenital heart defects. So you need to look for congenital heart defects, and you need to look for more systemic anomalies. we don't really know the exact embryologic etiopathogenesis. However, it is whatever happens quite early in the pregnancy at around 20 to 30 days of gestational age. Most of these cases are non-syndromic and isolated. However, some of them do show inheritance patterns, and some of them are associated with Carter-Jenner syndrome and primary ciliary dyskinesias. I want to highlight the heterotaxy gene that has been described. It's on long arm of chromosome X, and it's responsible for around 75% of X-linked heterotaxy syndromes and around 5% even of isolated heterotaxy syndromes. Other genes dealing with the laterality are also identified and most likely are implicated in these conditions. So I thought I'll take this opportunity to discuss fetal autopsy in general a little bit, and to discuss what we as pathologists need from the clinicians when we do fetal autopsy. So what we basically need is a detailed requisition form with attached all the investigations that have been done, all the relevant investigations that have been done. We need to take a written and informed consent before doing the autopsy. Generally we take the consent of the father, and if possible prior intimation that a new case might be coming is always great. We accept cases between 11 weeks of gestational age and 7 days of neonatal life. 11 weeks of gestational age because the organogenesis is not really complete before that, and 7 days of neonatal life because beyond that perinatal causes of fetal mortality are really remote. We need our samples to be submitted in large containers with adequate formalin so that the fetus does not get distorted. And this is our requisition form that we have developed. We have a pedigree space for a pedigree chart and family history here. And this is the consent form. And this is typically how a fetus comes to us with a big braid box container, we call them, and adequate amount of formalin. Okay, let us discuss the approach to Situs anomalies. So, like it has been said before, it's not just the thoracic situs; it's also abdominal situs. And what we do is we go in a systematic way. We first examine the thoracic cavity, and then we go to the abdominal cavity. We open the trunk in an inverted Y incision. Now, this is generally, it varies from center to center. In the West, they generally open in a Y-shaped incision because most of the times the babies are returned to the parents. We prefer a inverted Y-shaped incision. And once the thoracic cavity and the abdominal cavity are open, we go to the examination. And thoracic situs, we look for cardiac apex. The location of the cardiac apex, is it left-sided or is it right-sided? We look for thymus if it is there. And we look for the lungs morphology. Is it the right lobe? Is the right lung trilobed, and is the left lung bilobed? As you can see here, we can identify the lingula here as well. Then, in general, as a fetal autopsy as a whole, we talk about pleural cavity and the pericardial cavity also. And then we examine the lungs in more detail, including the bronchial laterality. The examination of heart takes up bulk of our talk and bulk of our time, really. So we do a segmental approach with the main segments being atria, ventricles, and the arteries, and the connecting segments being the AV canals and the infundibulum. We look for position of each segment. We look for atrial situs and the features. We will discuss features of those. We look for ventricular situs and the relationship of great arteries. In a cardiac examination on the whole, we then talk about the relationships of all these segments to each other, and that is of value to Situs anomalies also. But I thought we will limit ourselves to just the laterality part of it this time. We look at branches of great vessels and then the internal morphology of the heart chambers. So this is just to highlight the segmental approach that we take. We look for the situs and then the cardiac position and segmental analysis and atrial situs and so on. And so this is the right-sided heart, so to speak. The right atrium, as you can see, as we have said before, the right atrial appendage is the where you identify the right atrium, morphologically right atrium. And so that's the key basically, that the morphologically right atrium has to be identified. It need not necessarily be on the right side. And if it is not on the right side, then you start thinking in terms of the situs anomalies. So right atrium, broad-based at right atrial appendage, and the right ventricle is kind of trapezoidal in shape with the, with the tapering side of the trapezoid towards the outflow. By contrast, the left atrial appendage is narrow, conical, and finger-like almost, as you can see here. And it has, you will see the openings of pulmonary veins into a normal left atrium and a left ventricle. And in this view, it's more or less circular or spherical. So that is how initially we identify the atria and ventricles. Then we go in detail in the internal morphology. The right atrial appendage, right atrium will show pectinate muscles, and you will see a fold of septum secundum. You will see coronary sinus opening, and then the opening into the tricuspid valve. By contrast, the left atrium will be much more smoother with the pectinate muscles just confined to the atrial appendage, and you will see a broad septum primum and then the opening into the bicuspid valve. Right ventricle, we see the pectinate muscles and the coarse trabeculations, and then the smooth infundibulum. That is how we identify the right ventricle, leading into the outlet with semilunar valve. Laterality of ventricles is also identified by the D loop. So D loop is the normal position, the right-sided loop. It's called basically, if you were to put your hand over the ventricle, the thumb would point towards the inflow and the fingers would point towards the outflow. And L loop, if you see an L loop, then that is situs abnormality, as you can see in this picture. Similarly, the left ventricle will be characterized by morphologic left ventricle, that is, will be characterized by fine trabeculations, and you will see a fibrous continuity of mitral and aortic valves. And then again, you will see a D loop, which is again the inflow point, thumb pointing towards, if you put left hand over the ventricle, the thumb pointing towards the inflow and the fingers pointing towards the outflow. So this is how we diagnose the laterality. In a normal condition, in a situs solitus, the right atrium would be, morphologic right atrium would be in the right side of the heart, and so on. The relationships of great arteries also varies according to the situs. In the normally, the aorta would be superficial and towards the right of the pulmonary trunk, and reverse in the situs inversus, as seen in these pictures. So I'm nearing the end of my talk. So like I said, we look at abdominal situs also. So the ileocecal junction should normally be in the right lower quadrant. The liver should be on the right side, and the stomach should be left-sided. The spleen examination, as was discussed by the previous speakers, is also important. You need to not only see the situs of the spleen, but number or presence or absence. And we need to look for atracheias in these cases, because atracheias are quite commonly associated with situs anomalies. So this is not a case of situs anomaly, but just to highlight, this was a case of duodenal atresia, and even there was quite a lot of malrotation and deviation of the situs, as you can see with the liver here. To summarize, we need detailed clinical history and imaging findings from you, and we promise we do a very thorough fetal examination. I just wanted to highlight the third point here, because like sir said in the first case, the recent trend, or at least I should say the recent updates, recent train of thought is that rather than giving it a single name, rather than calling it ambiguous or inversus or heterotaxis syndromes, we should be probably going in favor of a descriptive diagnosis. So calling it as situs ambiguous and then just enlisting all the findings that are seen, because that will give a detailed picture to our medical geneticists and fetal medicine consultants, and it will provide inputs for further genetic analysis and counseling. These are my references. Thank you.
Thank you very much, Dr. Aditya, because that is a completely different perspective. When we look at it in imaging, we see different things, and the way you approach it postnatally is very different, and you have the advantage of looking at all the other visceral arrangements as well. So with this background, we will now move on to the next part of this program, which is a expert panel discussion and audience interaction, for which I would request Dr. Khurana, Geeta Madam, Dr. Praveen, and Dr. Adinarayan Makam to please answer some of our queries of our audience, and then give us some insights into this really complex topic, because although our presenters have presented these cases in a simplified manner, it is actually a big challenge when it comes to handling any case with situs anomalies. So this is a formality of having the CV of the experts here, but again, who is going to introduce Dr. Khurana to Society for Fetal Medicine? Dr. Khurana, I would say, is a lifelong teacher and an excellent, inspiration for anybody who wants to do anything good in life. Thank you, sir, for being with us. Dr. Praveen, again, somebody whom we look up to every time. He's one of our legendary ultrasonologists here from Hyderabad and an excellent teacher. All of us look up to him. He has lots of achievements in his life, and I have personally seen him receive Lifetime Achievement Awards. So, sir, welcome very much to this evening, and we're looking forward to hearing from you. Dr. Geeta Kolar is a senior consultant in Fernandez Hospital here in Hyderabad. And again, another very passionate teacher and a very, very strong academician. We've already met Dr. Adi. So I will just start with the first few questions, which are from the audience. And then Dr. Shagun, please come over, because some of these questions will have to be from the genetic perspective as well. So the first question is, how much is the rule clockwise spine, stomach, and portal vein in cephalic presentation for situs applicable?
You want me to say?
Yes.
Dr. Kiran has asked this question. How much is the rule clockwise spine, stomach, and portal vein in cephalic presentation for situs applicable?
Can I take it?
Yes, ma'am.
Yeah. See, it is applicable, provided you have seen the lie of the fetus properly and you have oriented the probe properly. I think everybody has a habit of rotating the probe, angulating it, dipping it, and then you would orient it differently, then you do not get the situs problem. So the 4 images that we save are the presentation, then the side of the occiput, then we take an axial section of the abdomen and axial section of the fetal thorax at the level of the forecheck. And that's when, if you have not changed or rotated the probe, then okay, this is a cephalic presentation with the occiput to the left, the fetal heart is on the left. So unless you orient yourself to the right and left of the baby with the lie, nothing is applicable. But if you're oriented yourself to the lie and to the right and left sided, I think the clockwise and anti-clockwise holds very good. We've never had an occasion to doubt it.
Ma'am, I just want to make one point here, because some of us scan with our left hands. And when we do that, even in the correct position, the way we scan where the head of the woman is towards us, the other side, and the machine and the feet of the woman are on the same side, actually this works. But if the lady is turned around, if her head is the way when you do a right-handed scan, then this does not work. It just becomes reverse there.
Sure.
So in the case of patients who work with operators who work with left and right side differently, I think imagining yourself in the baby's position would be an easier method to establish situs. Otherwise,
there basically we go by taking into consideration the presentation, lie, as well as the relationship of fetal spine to the maternal spine. I think this is one of the ways by which you can easily correlate with.
So this is one way we teach people is the handheld doll method, which is actually just imagining yourself in the fetal position. And if you can't imagine, then you hold a doll and try to orient yourself with that. And the other one, of course, is this thumb rule. So, I mean, I just want to take from all the experts here, what would you think would be the best way to establish situs for everybody here?
There's nothing like a best way. Everything is good in the sense the thumb. Some people very ardently practice this hand rule, whereas some prefer to use the expecting yourself in the patient's and the baby's position and trying to identify the situs. I think it all depends on the convenience of the operator.
Dr. Adi?
If you ask
You're the
me,
designated expert.
No, come on. If you ask me, my personal view is none of the rules work for me. I'm a simple obstetrician. I can't remember clockwise, anti-clockwise, breech, especially when I'm stressed with an abnormality. I don't want to use my brain. My simplest approach is you imagine yourself in the mother's tummy, but that also I may have to do some dancing activity to know where I'm lying. So my approach, and that's what I teach my fellows also. In the first few cases, take a doll and keep the doll, do the survey and keep the doll in that position. After 2 or 3, you don't need a doll. You can throw that away. You have to know where is the fetal parts anyway for any diagnosis. So why don't you train yourself to get a 3D reconstruction in your mind when you're doing a scan? That would be the easiest. So then it won't take more than a fraction of a second if you train yourself to know the situs. Easy. Thank you.
Many years ago, I decided to do exactly what Adi does. And it's nice to follow him because you can always blame him for anything that goes wrong. The thing is that, you know, with these dolls, we made a few mistakes. And some of these dolls turn around their waists and their waist turns around because everything is fixed onto everything else. So it doesn't work. So I just like to put myself, as he said, into the maternal abdomen. And it really seems to be the only way that works each time. And then your mind gets tuned if you learn how to use it early enough, good enough. If you don't learn how to use it, you learn to do it sooner or later anyway. After you made your first 2 mistakes, you feel stupid enough to say that, no, I have to handle life correctly. So it's nice to make a few mistakes in the beginning and then say, no, I need a system. The simplest system is really to put yourself into the maternal abdomen, and it always works.
Thank you. Geeta ma'am, you were saying something.
No, another way is all the machines have these images which you can put on the screen. You know, you have these indicators, the small doll-like things on your images. You can actually see, like Adi said, sometimes you're too tired, a baby is transverse lie with head up, you have twins. So those are the cases where you don't know what side is where. So there are these emoji kind of things on your machine. You can put these and then you can orient yourself that way, or keep a doll next to you. But those machine emojis work quite a bit. They really are useful.
Of course, all of this will become quite rare for the next generation because we have recognition. So automatically, your machine will tell you that the stomach is not on the same side as the cardiac apex. And your machine will tell you that the cardiac apex is pushed rather than turned, because there is artificial intelligence. And not something really, it's not for tomorrow, because we have equipment today which is commercially available at actually a cheaper cost than what some of us use. And it actually identifies the stomach, it identifies the heart, it identifies the vena cava, the aorta, and everything else. And there's pretty much not much else that you can identify. We're now working on trying to do anatomical recognition of the portal sinus with its curve to the right. And In fact, that's the next bit that's going to be added onto the same machines. And this artificial intelligence is not something that will happen after a few years. It happened 2 years ago, and the machine is on sale. It's from a fairly famous vendor. It's called the Swift, and it has all this, which is instant recognition, and the machine will tell you that, look, this is visceral situs and this is cardiac situs. So the new generation has it all worked out for themselves.
That's great, but I think at any time, natural intelligence should precede artificial intelligence, and we should have a method.
Artificial intelligence, there's no doubt. The first rule of artificial intelligence is it requires your supervision and mine.
True, sir. So for Situs, this is what everybody has to say, and that's something which has to be the first step when you start scanning, because orientation is one of the most important points there. Then I think there's a comment by Dr. Hemangini that there was dextrocardia and not dextrogastria, and that's what I thought said Dr. Kiran. I suppose this is to that second case which we presented where there was a left atrial isomerism. So no, there was dextrogastria based on the Situs assessment as was done earlier. So it was a dextrogastria with a levocardia. In which category does isolated mesocardia fall? Dr. Adi?
No category. It's mesocardia.
So it doesn't form, according to you, it is not a Situs issue. It's just an axis deviation.
Yeah.
And Dr. Sumati Natarajan asks how to approach cases with isolated altered cardiac axis without any structural problems. So there you are. Praveen sir, would you like to take this?
No, come again. I can get the question.
How should we approach cases with isolated altered cardiac axis without any structural problems?
But then whenever there is an axis alteration, that is, you mean to say the cardiac axis, whether it is right-sided or left-sided, actually there is a wide range of axis in the 45 degrees plus or minus 20. So quite often when there is an associated one, then we give importance to this axis deviation. But then isolated without any structural abnormality as far as the heart is concerned, or any other extra cardiac abnormalities which could be responsible for axis deviation, if they are not there, I think we consider it as a variation.
And be mindful of those few problems like, partial anomalous pulmonary venous connections and things, because those things can pop up later on. You may not have seen them antenatally. So the next question is specifically to you, which I think you've answered there, but for the benefit of all others, how can we identify atrial appendage in sonography?
Basically, I think I have answered it, but then anyway, appendages are a little difficult to identify as far as the ultrasound is concerned. In principle, when we think in terms of a left atrial appendage, it is usually finger-like, or basically we depend on the left atrial morphology rather than the appendage in order to give us an answer. Usually the left atrium has got what is called as the sickle-shaped appearance. And that is the reason why the appendage becomes finger-like or a finger-like projection. Whereas the right atrial morphology is broad and blunt. That is the reason why you have the right atrial appendage being pyramidal shaped. So as on ultrasound, sometimes it is very difficult to identify the left atrial appendage and the right atrial appendage. Whenever there is a problem like that, you need to go into the morphology of the right atrium and the left atrium, which gives you an answer. So I think that's how I approach.
Thank you, sir. And there's another question from Dr. Aradhya Bhagat. What is the position of the left ventricle and right ventricle in isolated dextrocardia, which is on which side? Geeta ma'am.
No, isolated dextrocardia, it just says that the heart is onto the apex of the heart, right side. That's it. So unless it is associated with other abnormalities, the importance of identifying the left atrial morphology or the right atrial morphology depends on the morphology that has been identified in that particular case. It cannot be generalized.
Chinmay,
Yes, sir.
Can I add? I mean, as Aditya said earlier, we need to give a descriptive diagnosis rather than a diagnosis. And especially with this dextrocardia, dextrorotation, dextroposition, it causes a lot of discomfort for so many of us. So all we have to do is to say that heart is in the center, directed towards left, heart in the center, directed towards right, rather than saying dextrocardia, dextrorotation, dextroposition. I fail. So that's if every one of us fall, at least we describe what we've seen. That is more important than the actual terminology itself. Even for heterotaxy also, why do we have to break our head to say it's left and right? 10% of them are indeterminate. And only what we need to do for a clinical management, we need to know what are the abnormalities, what are the observed ultrasound abnormalities. That's what we have to depict. That's what I feel.
No, that's, I think, a very practical approach. Dr. Khurana, would you like to comment on it?
I agree completely. There are so many different names that are used, and equally importantly, pediatric cardiologists like to use different terminology, and it's no fun trying to be on a different page just because we are somebody and they are somebody. So for the sake of the patient, it's much nicer to actually give a nice detailed description. You can use some words in a conclusion somewhere, but the detailed description must be nice and prominent, giving each step exactly as we've learned in the first half of today's talks.
Because I think the definitions will apply to only those cases where all the components of the definition are fulfilled. But that seldom happens, and therefore a descriptive diagnosis will always be better because that continuity of understanding will be there. Whoever scans after this first person will know exactly what were the findings that the first person was encountering. So there is another comment by Dr. Prajakta. One of the cases of left heterotaxy has SVT. Please explain. SVT, I assume, is supraventricular tachycardia. I don't think we had a case with supraventricular tachycardia, did we? We had bradycardia in
complete heart block.
because there was a block in that case, and that, as Dr. Adi also mentioned, because the conducting system of the heart originates from the right atrium. So when you have a left isomerism, you're likely to have a heart block, which is in the definition of the left isomerism. Then Dr. P. Radhika says, a case of elderly primate, 36 years, with query heterotaxy, query congenital heart disease, with an interrupted aortic arch and bradycardia. Gives a history of a partner with situs inversus totalis, and partner's grandfather also has situs inversus totalis. As they opted genetic testing, which is the best test to be advised in case of the family history with situs issues? I think I'll bring on Dr. Shagun here. She's actually...
Yeah. So actually, no, I think maybe like we can take this. Shall I just share my screen?
Yeah, you please share. She had a set of questions to discuss. Please do.
Yeah, so let's know, because we've discussed the morphology, the ultrasound and the autopsy. Just to answer this question and also other questions pertinent to genetic testing. So I'll just share my screen once. So I hope it's visible.
Yes, yeah, now it's visible.
Okay, so just to like, I mean, you know, like everybody has said that it's a descriptive diagnosis actually, which basically makes a difference to the patient in terms of prognostication in pregnancy and management after birth. So that's actually the main, we can say, the running kind of the basis on which these cases, these cases are managed. But still there is a role of genetics. So traditionally it's believed that, these heterotaxy and the other situs inversus and all these situs abnormalities are more sporadic. That's the kind of a little bit of a myth or kind of a traditional concept which is there. But there is a significant contribution of genetics. So, and we need to realize that which case, what test to offer, because it makes a difference to the patient actually. So this, anyways, we've already had a, discussion that it's not possible to classify, to name often, and we always have lot of variability. And despite some of the very well-defined phenotypes, there is a lot of things which fall in between. So for the patient's best interest, it's best to describe. So this was actually one of a very large study of some 18,000 patients with cardiac defects.
Sorry, your slides are not moving. So can you just make it full screen
and full screen?
Full
Is
screen.
it not
Full
full
screen
screen?
and move them. Huh?
Full screen, full screen.
Okay, actually it's full screen for me. I don't know. 1 second.
Just
I'll do
start
it
sharing
again.
again. Yeah.
Yeah, I'll do it again.
So because we all remember being told that we don't need to do karyotyping if it is
Yes, that's
heterotaxy.
exactly,
So,
yeah, why, right. So is the
no,
screen
make it full
visible
screen.
now?
Huh.
Yeah, just a sec, I'll make it. Is this full screen now?
Not as yet.
Not as yet.
Some issue.
You
Not
want me
yet?
to share it? I have your presentation.
Okay, sure, please do that.
Yeah, just you
Yes,
unshare.
I'll stop share. Yeah, so what I was just saying, that there was a huge study, in fact, where they studied all the cardiac defects, and they tried to see that how common was it for a particular type of cardiac defect to recur in a family. And there, in fact, they found that these situs abnormalities were the ones which had the highest recurrence risk ratio. So, which means that if you compare people with the family history of a situs abnormality, they are much more likely to have another person in the family with a situs abnormality, and this ratio is as high as 79. And as compared to VSD, where it was lowest at around 3.4. And then there is also some empirical data which is there based on recurrence and all, which says that around 5 to 10% cases recur. So actually both these statistics themselves point in the direction that there is a genetic contribution, there is a significant recurrence risk which is existing. So, but why we are missing it is the fact that all these years we were basically focusing on doing a karyotype. So in fact, a karyotype is one of the least, and karyotypic abnormality is the least common association with heterotaxy or a situs abnormality. So very rarely you would find a trisomy 13 or 18 with a situs abnormality. Otherwise, the karyotype will be normal. So all these years we were thinking that there is no genetic association because the karyotypes are coming back normal. But then now, as as with ultrasound technology advancing, we have now genetic technology advancing, and we're able to see so many other things. So there have also been reports of diGeorge being associated with situs abnormality. Again, this is very rare. But then there are various animal models and some human studies, and now there are more than 100 genes which are known to be associated with laterality. In fact, we'll go to next slide, Chinmay. So the most common, which Dr. Aditya also mentioned in his talk, is the ZIC3 gene. So this was the first gene which was known to be associated with situs abnormality. So in fact, if you see a family, if the fetus is a male, so if the fetus is a male and you are seeing heterotaxy, then think of this gene. And especially if there is a family history and it is looking like an X-linked inheritance, which means that the fetus is a male and maybe there is a male sibling with a situs abnormality, or it may not be a situs abnormality. It may be just a cardiac defect. So which is not fitting into situs abnormality per se. Or there could be a maternal uncle. So this is X-linked inheritance. Males are getting affected, females are not affected. So in such cases, more than 75% have mutation in this gene. That is the ZIC3 gene. And then there are various other genes. Here, the main thing which is important to kind of differentiate is the situs inversus. The classical situs inversus, where there is no confusion. You have a pure mirror image. So these cases are actually, we know ourselves also that they have a good prognosis, most of them. And we see so many people who are incidentally detected as adults, as children with situs inversus. So if you are seeing in a fetus that it's looking like a complete mirror image, there is no confusion, then in those cases, in fact, that can be part of something called as a primary ciliary dyskinesia. And they are actually relatively good prognosis cases. Cardiac defects will be seen only in 5 to 10%, and they will mostly, the problems they will have will be related to infertility or recurrent sinusitis or sometimes recurrent bronchiectasis, but they don't have intellectual disability, they don't have other visceral abnormalities. These are the good cases actually. So the pure situs inversus ones, but the other ones, all the other ones, of course, fall in the heterotaxy spectrum. So there if the fetus is male, think of ZIC3. And if it's not male or otherwise also, then there are so many other genes, and these genes actually all function. I don't want to go into details, of course, this will become too boring, I guess, but these genes all function right at the time of gastrulation. So at the time of gastrulation, when the baby is, still deciding which is its top, which is its bottom, what is left, what's right, that's the point when all these genes come into play and they actually decide something like which side should become left and which should be right. And it's the disturbance of these all things or these all pathways which cause all these problems in the situs. So next slide we'll go to. So what test should we doing? So what the doctor has asked. So here we are having like a family where the baby has a situs abnormality and there is also the father and one more family member. So grandfather, I think. So this is classical autosomal dominant inheritance. One generation to next generation to next generation, there is a situs abnormality, and it need not always be the same type of abnormality. That is the whole I can say the beauty of this, or whatever the complexity of this situs, that sometimes it can be heterotaxy, sometimes it can be situs inversus also, sometimes it can be just an isolated cardiac defect like a VSD for all, just a VSD in the same family with the same mutation. So there is so much of variability. So, and there are so many, so that's what the family she mentioned is autosomal dominant. We can have autosomal recessive, we can have X-linked recessive, which is mainly ZIC3. So all kinds of inheritance patterns are possible. And overall 15 to 20% cases with a situs abnormality will have a single gene etiology, means that there would not be a chromosomal problem, there will not be a microdeletion, microduplication, there will be a problem at the level of an individual gene. And these are the cases because there are so many genes involved. So you have to do something called as exome sequencing. So the answer to the question is that the test to be done is exome sequencing, because this is the test which is going to look for mutations in all the genes which can cause situs abnormality. And then in that's how you are able to kind of reach a diagnosis for that family. And then depending on that, we can of course predict a recurrence risk. So if for dominant you have 50% recurrence risk, for recessive it's 25%, for X-linked if mother is a carrier it's again 50% for male babies. So depending on the gene, depending on inheritance pattern, you can tell the family what is the chance of recurrence. And it is in fact very important here in this site, the cases of heterotaxy, because many patients would actually go on to terminate these pregnancies. So they will not be interested to do anything because the baby has a poor prognosis, but then doing genetic test helps them provide proper counseling as to for the next time as to what is the recurrence risk. We can offer them prenatal, we can offer them PGT next time. And also besides exome sequencing, we should also offer microarray. I would say in our Indian settings, exome sequencing is the first test we should do if there is a situs abnormality, because in our own experience, we are seeing that most of our Indian babies are having autosomal recessive conditions, most of the cases, because we are so much endogamous. We marry in the same caste, the same gotra and all those, and consanguinity, especially in south part of India. So for us, microarray doesn't really work most of the times. At least our experience has shown hardly any baby has any microdeletion, microduplications. Most babies have either a aneuploidy or a problem in the exome. So here in heterotaxy, we should directly go for exome. The karyotype will also mostly not yield anything. And then encourage an autopsy. Again, as Dr. Aditya said, so we really need to, autopsy is going to give you so much more phenotypic information, which we are not seeing on scan sometimes. You may miss some small things. So you do an autopsy, you find that information, collect proper samples. So if the patient is willing, do amniocentesis. Otherwise, at birth, collect either of these samples and then consult with the geneticist so that they can guide you for, again, subsequent testing. And then, of course, as I said, this is important implications for further pregnancies. And one more important point, like which is there, is that even antenatally, suppose you are seeing some situs abnormality, like one question was that there is an isolated dextrocardia. So that's all you are seeing. So one thing is that we should be aware that there could be something else which you are not able to see right now. So even in an isolated dextrocardia, if you do exome sequencing and if you're able to find a particular mutation, then depending on the gene involved, we can get some idea of the prognosis. So we can get some understanding as to, is this dextrocardia really isolated or could there be something else? Because we have some idea that this gene mutation causes this kind of problems in after birth of the baby. So even antenatally, especially the milder cases where the patient may be thinking of continuing the pregnancy, those are the cases where you should in fact antenatally also do genetic testing. So I think, from my side, these are the things we always, for all cases, genetic testing has to be done. That's what would be the message.
Wonderful points, Dr. Shagun, because that is a myth that, we don't need to do genetic testing in heterotaxy. Yes. So as you very clearly brought out, an exome is important. It could be genetic, and at least if you do a microarray, you might get. So the karyotype not being important was because karyotype related problems may not be there, but yes, they may be less than that. So we've saved the best for the last, and I'm going to ask Dr. Adi to give a little summary on, heterotaxy, so that all the 163 people who are still logged in go home with some really golden take-home messages.
Right, many of them have heard my lecture, I think. So I just, how much time do you have?
Till we all log out.
I'd like to give him unlimited time. This man is so good with heterotaxis. He puts everything that we can remember it correctly for the next 3 months.
I couldn't hear most of it, sorry.
I said you're so good at heterotaxis, we want to carry home that message for the next 3 months.
Okay, fair enough. Very nice. Thanks, bro. Thanks, big boss. I know heterotaxy, if you ask anyone, that's the last chapter they want to read, tend to read, and most often they don't read. They open the first page of heterotaxy and it all goes for a toss. That is same with me. I was thinking, how the hell I can make a diagnosis of heterotaxy? I'm just a poor obstetrician. So it irritated me. So I thought there must be some easy way to make a diagnosis. But if there is an easy way, then there is bound to have some false positive, false negative. So I said, my current diagnosis detection rate of attributing a correct heterotaxy is around 0%. So if I get to 10%, 20%, 90%, I'm very happy. So I retrospectively gone through all my cases, and I was going through the heartache. How do I make a diagnosis? So finally, decided there should be easy method. So that's what, if you want me to present, I'll present few slides. Shall I?
Yes, please.
Okay, good. Shall I share my screen? I skipped most of it, all of you know, but only one point I want to make here is you cannot look at any of the internal thoracic or abdominal structures to make a diagnosis of laterality. You can't see the 3-lobe lung, epartial, hypartial. These are all easy for Aditya.
Can you see polysplenia?
Yes, polysplenia, asplenia, good. So you could see splenia, polysplenia, asplenia by little bit more attention, and if you see normal spleen in a normal fetus, then you tend to identify the structure a little bit easier. You can use color to see the splenic artery, but whether it is asplenia or polysplenia, both are non-functional. So it will clinically do not make any difference. You diagnose splenia, asplenia, and sometimes you don't know. It is not easy to. They will not be in the same position as normal behind the stomach. At that time, it's very difficult because the bowel also have a similar echogenicity. So practically, there is no need, and it is not required, and it is not easy to look at the spleen and make a diagnosis. So forget about it. None of them will help. So what would help is your vascular connections, and it is quite easier. The IVC is on the right side, and the pulmonary veins are on the left side. So looking at these two, we should be able to make a diagnosis of heterotaxy. in about 90%. So that's what I wanted to emphasize. One second. So some of the things are already discussed. I'll just flip through. So if there is a arrangement, normal arrangement, we call it a situs solitus. And if it is a complete mirror image, we call it as situs inversus. And if it's anything in between, we call it as heterotaxy. So that's probably the simplest way of understanding heterotaxy. And in ultrasound, I said we can't see any of the structures to make a diagnosis for certain. And I want to make one point about atrial appendages. Atrial appendages are diagnosis under pathologist. If we ultrasoundologist or a fetal medicine specialist, even the pediatric cardiologist will find it difficult to identify the appendages appropriately. And if you ask me, I can convince anybody to say this is left and this is right. So it is very difficult to make a diagnosis looking at the atrial appendages. One point, if you want to see the right atrial appendage, the hammock view will help you. And if you start seeing the appendage morphology in normal cases, sometimes you may identify in a heterotaxy. But by and large, looking at the atrial appendages is practically of no use. So all what we are left with is only the vessels. So looking at the vessels, how can we make? I'll take you through. So in a left heterotaxy, the baby does not know what is the right side structure. So what it does, it doubles the left side structures. That's why it's called left heterotaxy. The opposite is the right heterotaxy. So I'll flip through, I'll show you the cases, and then I'll tell you how to diagnose. Okay, so now this is I have 4 or 5 simple cases. I can see this is a 13-weeker. The stomach is on one side, the apex is on the other side. So is it a situs ambiguous? Of course, it's a situs ambiguous. So then once the situs ambiguous, your antenna should go up and see either any cardiac abnormality and also look at the vessels. So here, this heart is beating at a lower speed. If you have a bradycardia less than 16 weeks, is almost invariably, it's a heterotaxy, and almost invariably it is left heterotaxy because your conducting system belongs to right side. This fetus does not know what is right. So what it does, it makes the left side structure both on the left side and the right side. So your conducting system will go haywire. So that's why you get bradycardias or bradyarrhythmias in a left atrial isomerism or left heterotaxy. So you may have cardiac abnormalities, not necessarily need to have cardiac abnormality, but many of them will associate with cardiac abnormality. This is a ABSD. Don't need to do all those things. So the diagnosis was situs ambiguous and a heart block. So immediate diagnosis would be your left heterotaxy because this baby has not understood what is right. So it has done 2 left-sided structures. Stomach on one side, apex on the other side. Stomach is on the left side, heart is on the right side. So now, in this case, you can see there are 2 appendages appear similar. This is a normal one. This is left-sided, this is right-sided. So looking at the atrial appendages and start making a diagnosis, it will be difficult. So I don't want you to go looking at the atrial appendages. Now, we come to vessels. What are the 2 vessels? IVC and pulmonary veins. Here, if you can see, the red one is a IVC. Red one is IVC. Soon after the kidney, it disappears and the azygous continuation will be there. So you have 2 vessels next to each other, aorta and azygous vein. So why there is azygous vein? Because IVC is interrupted. IVC belongs to right side. So this baby has not understood what is right side. It has doubled the left-sided structure. So what is the diagnosis? Left heterotaxy. So by just looking at double barrel, where did we see? Behind the heart, behind the forechamber. 2 vessels, double barrel, it's left heterotaxy unless proven otherwise. This one, there's referred for abnormal ductus venosus. Is there a situs ambiguous? Originally, I thought it was a situs ambiguous, but cardiac apex and the stomach on both are on the same side and belong to left side. So do you need to have a situs ambiguity in making a diagnosis of heterotaxy? Not necessarily. In left atrial isomerism, as Sudha told, out of the 3, 2 are sufficient. So you don't need to have a situs ambiguity. So you have a cardiac abnormality, ABSD, in the same fetus, and the baby had bradyarrhythmias. So again, the conducting system belongs to right side. Right side system is not working. Left side structures have become doubled. So what is the diagnosis? Left heterotaxy. Okay, so this one, again, the stomach on one side, apex is on the other side. There is a cardiac abnormality. So aorta and IVC are on the same side, so they're juxtaposed. So juxtapose IVC you see in right isomerism. So I don't want to make a diagnosis there. Come back to your area behind the heart. So look at the area behind the heart is very busy. I've reduced the PRF, that's why it's a little bit bleeding. If it is very busy, vascular, in terms of vascularity, then you should suspect TAPVC. So these pulmonary veins are not entering to the left atrium. So pulmonary veins belongs to left side. So this baby has not understood what is the left side. So pulmonary veins will not go into the left atrium. They form a anomalous connection. So that means baby has not understood left side. So it has to be right heterotaxy. The last one, or maybe I'll skip this one. Easy peasy. Now, the last one. This is a BMI of my BMI, maybe a little bit more than my BMI. Hardly you could see the heart, but in less than 2.5 seconds, you could make a diagnosis. Stomach on one side, heart on the other side, and what did you see? Double barrel. So this is, one of them is a azygous vein. Azygous seen, that means IVC is interrupted. That means baby has not understood the right side. So it has to be left heterotaxy. Okay, so we've made 25 cases of situs. Okay, I'll just give you a last summary slide. First, what you should do clinically when you assess any fetus, look at the situs. How do you assess the situs? You adapt whatever technique you want to, as long as you make a proper diagnosis, it's fine. So stomach and heart, if both are on same side, and if it happens to be on the left side, then it is situs solitus. If stomach and heart happens to be on the same side, but it is on the right side, then it is situs inversus. If stomach and heart on the opposite side, then it is heterotaxy. Now the next question comes, how do you know which is right, which is a right heterotaxy or left heterotaxy? Where do you look? You look area behind the heart. If you see double vessel in area behind the heart, that means azygous vein is seen, IVC is interrupted, baby has not understood right side, it is a left heterotaxy. And if you see a TAPVC, that means left side structures are not working, baby has not understood the left side, so it has done two right-sided structures. That's a right heterotaxy. So this is the simplest formula I could ever think about. Wherever I present, I really get a lot of applauses. Thank you very much. I personally very happy, got something to make it simple. I'm simple obstetrician. I don't want to complicate issue. People say, can you diagnose 100%? No, I will never able to get 100% diagnosis, and you don't need to do 100% diagnosis because the management by and large depends upon what abnormality you see. Okay, after first Ashok sir gave me a chance to speak in Delhi, second time when I presented, I forgot the name of a guy, he's from Hyderabad only. After 2 or 3 drinks, he said, "What a wonderful lecture you gave. You made heterotaxis very simple. I have a little bit suggestion." What is it? After 2 rounds of alcohol, he said, double vessel is left heterotaxy, baki sub right heterotaxy. He made even more simpler than that. If it works, wonderful. Thank you very much.
Thank you. Thank you so much, Dr. Adi. And you would have got a great round of applause if we had not muted everybody. I'm sure everyone is clapping there, or they're busy clicking a picture of that slide because it's just, heterotaxy 101.
Yes.
So fantastic. And see, we knew the right place for the person who understands everything out of place, isn't it?
No, I've not understood. Don't mistake me. I've not understood because I did not understand. I got this one. If I understood, probably I would have made it even more complicated.
Now we don't understand what you said. So the point is, thank you very much. You really simplified a thing, and see, that's what, no, if you can't explain it simply, you don't understand it well enough. So the best explanations are the simplest ones. Thank you so much, Dr. Adi. There was one question, I think still what Prajakta was asking, we misunderstood that time. She said that she had a case where she had left asomerism, but she also had SVT. Is that possible? She wanted an explanation. So any of the experts?
I think it's basically a conduction with SVT. I don't know how it can trigger off.
So probably that case would need a little more detail and something to be.
It may be coincidental, but coincidence is not always. If you have to explain the conducting system disorders based on the heterotaxy, that's because atria and ventricle may have disordered connections. So you would have conduction blocks rather than supraventricular tachycardia because of the reentrant mechanism. So I don't think that SVT is actually a heterotaxy phenomena.
So I think the first lesson which you gave in the beginning of the session, that instead of labeling it as heterotaxy, you could have a descriptive diagnosis of whatever you found there, and maybe you would have found some rare phenomenon that would actually open a door to a new diagnosis. So I think, I am personally very enriched with this session because heterotaxy has always been a challenge, and the way it has been simplified by all our experts, and particularly Dr. Adi and Dr. Aditya for the pathology, and Dr. Shagun for the genetics, and Dr. Khurana, Dr. Praveen, and Dr. Geeta for all the clinical inputs. I think it's wonderful. So any final words from our experts? Then we'll hand it over to Dr. Shagun for the vote of thanks.
I just want to congratulate Aditya. What a wonderful images. Life is easier if you open and see. Unfortunately, we are not that fortunate.
No.
Thank you, sir. Yeah, but I should say that most of those cases were not mine. I have had the good fortune.
You shouldn't say, stop.
Yeah. Coming credit where it's due.
Okay.
Praveen, sir.
Congratulations, Chinmay. It's a wonderful session. I mean, a lot of simplified aspects we have learned, and it's good because it becomes easy for us to practice in our day-to-day evaluations.
Geeta, ma'am.
It was a good session, excellent. I think simple points. I would actually start from live presentation, looking at abdominal situs. I think while we speak so much on this, I always go by the aorta inferior vena cava. Aorta to the left, inferior vena cava to the right, and inferior to the aorta. I think that gives you all the clue. Then you go and examine the heart. For me, that is always a good image when you're taking an ASIC. I would really insist on that plane very, very much. And then you go to the heart, and then you get all the clues, I suppose.
Okay, thank you. Thank you, ma'am. Khurana, sir.
I think yes.
So, Aditi, over to you.
I would like to invite Dr. Shagun now for a vote of thanks for tonight's session.
Thank you, Aditi. So like after this wonderful session, I mean, it's really kind of my pleasure and privilege to offer the vote of thanks. And this has been our second monthly meeting of the Telangana chapter of SFM. And like, we're really grateful to Dr. Khurana and Dr. Praveen and Dr. Geeta and all our mentors, all our seniors for providing us this opportunity. And as always, we've had a really invigorating program today. And I would like to first thank Dr. Chinmay because she has really compiled this wonderful series today. And she's been very proactive and has been kind of prodding everybody to present. So really thanks to her for organizing this. And then I would like to, of course, thank our senior experts, Dr. Adi Narayana. I mean, it was wonderful having you and all your experience on heterotaxy. It's been really great. And Dr. Geeta, of course. Then we have had a wonderful discussion in the first session. Then I would like to thank the presenters, Dr. Madhvilata, Dr. Sudha, Dr. Anuradha, and of course, Dr. Aditya, and who have shared their cases. And Dr. Aditya especially has shared the pathology perspective, which has kind of given us another viewpoint into the fetal situs. And finally, for the second session, I extend my thanks to Dr. Ashok Khurana and Dr. Thiel Praveen, who are, of course, the torchbearers for SFM, and they have actually always spearheaded the literally intense academics that is synonymous with our association. So it has really been a privilege to have them amongst us, as always. And finally, I would like to thank the audience, still 160 plus people who are still tuned in, and for their questions, for their active participation. And then the final thanks would be to the tech support, to Vishal, and of course, last but not least, the trade partners for their contribution and always. So I think with this, we can probably conclude this session.
Thank you, Dr. Aditi, for coordinating this.
I know. Thank you, Dr. Aditi.
Who's been calling all of us off and on. But really, it was wonderful. This is a really nice session. And I hope all of them liked it. Our next program will be on the 18th of May. And I really request anyone who wants to present their cases to contact Dr. Shagun or myself. And we'll be happy to take it forward. Thank you very much. Wish you all a very good night.
Good night.
Good night.
Good night.
Good night.